Thank you very much, Krista. So that was a very comprehensive introduction. So thank you very much for inviting me to MELSAC lecture series. Today, I will be discussing pain assessment in the ICU and the validation of an AI-based technology for ICU pain assessment. Our learning objectives for today's session is to discuss the sources of nociception and pain in the ICU, to identify the challenge of pain assessment in the ICU, to discuss the methods of ICU pain assessment, to understand the importance and complexity of physiologic measurements of pain, and finally, to discuss the common validation strategy for pain assessment tools. Pain is a common symptom in the ICUs affecting critically ill adults. Studies have shown that the prevalence of pain among ICU patients is as high as 75%. This pain is usually due to underlying illnesses, trauma, surgery, or nociceptive standard care procedure, such as turning the patient, endotracheal suctioning, or chest tube removals. Often pain goes undetected or untreated, which often leads to unnecessary prescribing, behavioral and psychological issues, and decreased quality of life for patients. Inadequate pain management is associated with negative consequences such as prolonged duration of mechanical ventilation and ICU lengths of stay, chronic pain development, and even higher mortality rate. Pain is a personal and multidimensional experience, which is defined by the International Association for the Study of Pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. The sensory dimension is evaluated via self-reported description of pain. The emotional dimension includes self-reported aversive feelings related to pain, such as feelings of distress. The cognitive dimension refers to the meaning of pain experienced by the individual. The behavioral dimension refers to the behavioral responses used to express or control pain. Finally, the physiological dimension refers to nociception and biological stress response. I'm going to describe you a clinical situation where I was the circulating nurse in the operating room for a craniotomy procedure. As some of you might know, cranial pins insertion is a method of stabilization of head and is known to be an intense noxious stimuli for this type of surgery. As the neurosurgeon was inserting the pins, the anesthetized patient was exhibiting pain-related facial expression. This clinical observation prompted me to alert the anesthesia team to reassess their administration of analgesics. To my surprise, I was met with a resistance by the anesthesiologist. His immediate response was, "This is just nociception." Clearly, we have different conceptions of pain and nociception. So should we treat nociception differently than pain in our practice? Nociception is a physiological response to noxious stimuli. Therefore, nociception is what we would call pain in conscious individual. Pain, nociception, and biological stress responses are distinct but related concepts. Noxious stimuli may lead to tissue damage and are encoded through nociception and biological stress processes. Nociception may lead to pain, and both nociception and pain may enhance biological stress response. Let's look at literature on pain in unconscious individuals. In a large multi-center study in the States, patients scheduled for surgery under general anesthesia were interviewed at least a week after anesthesia and surgery. Data from 19,575 patients have shown a total of 25 awareness cases, and 28% of them reported experiencing pain during the surgery. So what we can conclude is that both clinical practice and research shows we should treat nociception the same way we treat pain, because unconsciousness does not negate the experience of pain. According to the definition of pain, the patient's self-report is considered as the gold standard measure of pain. However, many patients are unable to self-report due to their developmental stage, for example, infants or preverbal toddlers, or having cognitive deficits or intellectual impairments, or patients with severe brain injuries or conditions requiring the use of sedative agents which alter the level of consciousness. When self-reporting is unavailable, practice guidelines suggest using alternative behavioral pain measures such as Critical Care Pain Observational Tool, CPOT, or Behavioral Pain Scales, BPS. But behaviors can be masked because of sedation or neuromuscular blocking agents or some neurological damages. Now we're left with no other valid measures to assess pain. Vital sign fluctuations, perspiration, which can be measured by the skin conductance fluctuations, or technologies such as nociception level index might be alternative physiologic measures of pain. In order to get an idea of alternative physiologic measure of pain, let's look at the neurometrics theory developed by Melzack in 2001. This theory established that it is the central nervous system, CNS, that is responsible for eliciting painful sensations. In addition to the role of CNS in pain perception and nociception process, this theory recognizes the role of biological stress response in pain processes. The disruption of hemostasis by injury or pain activates neural, hormonal, and behavioral activities to restore hemostasis. The activation of hypothalamic pituitary adrenal axis, or HPA axis, and liberation of corticotropin-releasing hormone, CRH, subsequently activates sympathetic system. For example, during transduction, release of norepinephrine from the sympathetic nerve terminals may result in increased heart rate or blood pressure. The short-term stress response may lead to release of catecholamines and subsequently fluctuations of vital signs and skin conductance. To conclude, based on the neurometrics theory of Melzack, pain is a multidimensional phenomenon which can be clustered into observable and non-observable categories. Non-observable indicators can be the self-reporting of sensory, emotional, and cognitive dimensions of pain, and observable indicator includes behavioral and physiological responses. Vital signs are readily available in the ICUs and ORs through continuous bedside monitoring, and especially heart rate and blood pressure are valued by clinicians in the pain assessment process. As discussed, projection of nociceptive stimuli to the hypothalamus and pituitary gland contributes to autonomic and stress-related responses such as tachycardia, hypertension, and tachypnea. However, the practice guidelines dissuades the use of these physiologic responses for ICU pain assessment, stating that vital signs alone are not valid measures of pain. So why is that? Evidence-based practice requires the use of reliable and valid tools or parameters. Before we move forward, let's discuss the concepts of reliability and validity. Reliability is a necessary condition of validity and refers to the consistency of values when the construct being measured, in our case, nociception or pain, has remained stable. Test retest reliability is a strategy to evaluate whether the tool or parameter yield similar values over time in stable conditions. For example, when we assess pain before and after a nociceptive procedure, we may obtain similar values in patients with stable conditions. Validity refers to the ability of a tool or a parameter to measure what it is supposed to measure. Commonly used and relevant validation strategy of physiologic parameters for ICU pain assessment include the ability of the parameter or tool to discriminate two different conditions, such as nociceptive versus non-nociceptive procedures. This is known as discriminative validation. Another validation strategy is that the correlation between the parameters and either patient self-report of pain, which is a gold standard, or an alternative behavioral measure such as CPOT or BPS. This strategy is known as criterion validation. Going back to the topic of validity of vital signs for pain assessment, so why they're not valid for this purpose? We conducted a narrative review to answer this question. Our results have shown none or poor correlations between vital signs and pain reference standards. This is the major reason for concluding that vital signs lack validity for pain assessment, the lack of criterion validation. On the other hand, some vital signs increase up to 20% during nociceptive procedures compared with rest or non-nociceptive procedures. These findings support discriminative validation of individual vital signs. But these changes are not always clinically significant. ICU experts consider an increase of larger than 20% in vital sign value as clinically significant. So vital sign fluctuations of 15 to 20% might not be clinically meaningful. How about perspiration? Patients can sweat if they're in pain. Studies have shown skin conductance increases during ICU nociceptive procedures. So why not using vital signs and skin conductance if they have some validity? There's also another limitation of using these parameters individually. They're not specific to pain. Evidence shows that they could be influenced by other physiological and psychological conditions. For instance, shock, cardiac arrhythmias. Medications such as beta blockers may result in vital sign fluctuations. In addition, studies that evaluated perspiration through measuring skin conductance in ICU settings have reported that the skin conductance fluctuation can also be a response to psychological factors such as agitation when considered alone. For example, in one study, the skin conductance response to a nociceptive procedure was higher in ICU patients who were agitated compared to those who were not. In summary, we can conclude that these parameters, when considered individually, are not specific to pain because they can be influenced by other conditions. A new approach for physiologic assessment of pain could be the simultaneous combination of multiple physiological parameters. The nociception level index, the NLI, is the only available multi-parameter technology that was preliminarily designed for anesthetized patients, and it incorporates some vital signs and skin conductance in its algorithm. The NLI's finger probe has a disposable sensor that includes 4 small parts. From them, heart rate variability, photoplethysmograph pulse wave amplitude, which is indicator of arterial blood pressure, and skin conductance and its fluctuations are extracted. They are integrated and analyzed simultaneously to provide the NLI index ranging from 0 to 100. Values above 25 are indicative of nociception and related pain. The idea of multi-parameter approach versus individual parameters approach for assessing pain was first evaluated in healthy adults. The multi-parameter approach was initially evaluated in 45 healthy volunteers who were exposed to tonic heat stimulus using self-reporting pain intensity in a study by Trister et al. In 2012. In this study, the stimulus included different levels of pain induced by tonic heat stimulus. There were no pain, mild, moderate, and severe pain. None of the individual parameters differentiate between mild, moderate, and severe pain, and only combination of parameters significantly differentiated between all pain levels. Disability is also more relevant to clinical practice, as our goal is not just to identify the presence or absence of pain, but also to differentiate between pain levels. As discussed by Trister et al., the combination of these parameters may have a stronger link with pain and therefore strengthen the multi-parameter approach for pain assessment. Following these findings, Ben-Israel et al. In 2013 developed and conducted the validation study of the first multi-parameter technology, the null index, for anesthetized mechanically ventilated patients. The null was initially designed for anesthetized patients undergoing surgery. We conducted a review on validation studies of the null. A total of 6 studies with 234 anesthetized mechanically ventilated patients support discriminative validation of the null, with an increase of in null values up to 36 after nociceptive stimuli compared with non-nociceptive time points. Also, the null index performs superiorly in detecting the nociceptive stimuli with area under the curve larger than 0.90 compared with individual parameters such as heart rate, blood pressure, or skin conductance with area under the curve less than 0.70. This is a receiver operating characteristic curve or ROC curve, which is basically a graph, a graphical plot that illustrates the diagnostic ability of a measure. The closer the graph is to this point, the better the measure is. A random measure gives you a diagonal line, as you see here, which means that the measure is no better than chance. The diagnostic ability of a measure is no better than the chance. As it shows, the null's ability to discriminate nociceptive versus non-nociceptive time points was remarkably better compared to other single parameters such as heart rate, blood pressure, or skin conductance. Despite evidence supporting the validity of the null index in anesthesia, its validity for ICU pain assessment has not yet been established. One might wonder if it is valid in anesthesia, why we should reevaluate it in the ICU. As per Striner et al., the author of Health Measurement Scales, if the scale is to be used in a novel way, for example, with different populations, validity data must be gathered to support this new use. A tool can only be shown to be valid for a specific purpose, population, and context. As we know, anesthetic and sedative uses are different in the OR and in the ICUs. Therefore, as part of Dr. Jelina's lab, we conducted the first pilot and feasibility study of the null in the ICU, including those mechanically ventilated, for the purpose of pain assessment. We evaluated the null in 54 post-op cardiac ICU patients during 2 standard care procedures, chest tube removal, which is known to be painful, and blood pressure measurement using cough inflation, which is not painful. As you might know, these two procedures are standard care in post-op cardiac patients. Higher values were found during the chest tube removal compared with blood pressure cough inflation. A cutoff value of more than 26 was adequately classifying patients with moderate to severe self-reported pain intensity. Also, the NOLS value were moderately associated with self-reported pain. The second pilot study was in 15 conscious mechanically ventilated ICU patients during my master's. In this study, we evaluated the NOL during endotracheal suctioning, which is known to be painful, and blood pressure using cough inflation. Majority of mechanically ventilated patients in the ICU require endotracheal suctioning as part of their care. Similarly, in this study, higher NOL values were found during endotracheal suctioning compared with blood pressure cough inflation. Also, the NOL was associated with pain intensity and CPOT scores. To sum up, the discriminative and criterion validation of the NOL have been evaluated in our pilot studies. Other relevant strategies to explore are the test-retest reliability and another validation strategy called convergent validation, which is the ability of a NOL to correlate with another assessment method measuring a theoretically related dimension. Conceptualizing the pain as a multidimensional construct allows us to use another dimension of pain, emotional dimension, for validation process of the NOL. In our study, we will be looking at the association of the self-reported procedural pain distress with the NOL index values. As part of a larger CIHR-funded project of Dr. Julina's lab, my doctoral study aims to validate the NOL index for ICU pain assessment in mechanically ventilated ICU adults at different levels of consciousness. Specific objectives for my doctoral study are to examine criterion validation of the NOL using the gold standard self-report of pain and alternative standard CPOT scores during endotracheal or tracheal suctioning. Convergent validation using self-reports of procedural pain distress. Discriminative validation using a nociceptive procedure, in our case, endotracheal or tracheal suctioning, and a non-nociceptive procedure, which will be blood pressure measurement using cough inflation. Test-retest reliability, which is the assessing the NOL values before and after a nociceptive procedure. We will also have a complementary objective to describe nurses' evaluation of the feasibility and clinical utility of the NOL for ICU pain assessment, but I excluded it from this presentation to remain focused on the validation process. The larger CIHR-funded project of Dr. Julina will include all ICU patients, regardless of their ventilation status, as well as other nociceptive standard care procedures other than endotracheal suctioning. For this study, a prospective cohort observational design, including repeated measures, will be used. This study will be performed at 2 medical surgical ICUs in Montreal with a turnover of average 1,000 to 1,500 patients annually. To achieve our objectives, we will recruit a consecutive sample of 3 groups of ICU patients. Group A, patients who are conscious and able to self-report and exhibit behaviors. Group B, patients with altered level of consciousness and unable to self-report but can exhibit behaviors. And Group C, patients with altered level of consciousness, unable to self-report nor exhibit behaviors. We will assess patients before, during, and 15 minutes after a nociceptive standard care procedure, for example, endotracheal suctioning, as well as one non-nociceptive procedure, blood pressure using cough inflation. A total of 6 assessments of dependent variable of the study will be completed. Also, patients in group A will be assessed for delirium prior to data collection to ensure that reliability of their self-report. I should like to remind you that the larger CIHR-funded project will also include other nociceptive ICU care procedures, such as chest tube removal, drain removals, also arterial line insertion, IVs, and wound care. Our goal with this project is to contribute to clinical practice, research, and education. Identification of a valid physiologic measure of pain would be a significant advancement in ICU pain assessment. We are the first team to validate the null with multiple validation strategy for the ICU pain assessment. In addition, convergent validation of the null using emotional dimension will be evaluated for the first time in this project. If the null index is found to be valid, it could provide new perspectives on pain assessment training for all healthcare professionals and trainees. Special thanks to my supervisor, Dr. Jelena, who attended this talk despite her busy schedule, and other members of my committee, Dr. Richebet, Dr. Martel, and Dr. Lavoie. I would like to acknowledge that we received funding for this project and my PhD from the CIHR, the FRQS, the RISC, and the OIIQ MES. Thank you very much for your attention, and I would be happy to answer any question to the best of my knowledge.